I'm going to talk on anesthesia for a cleft lip and palate patient. So let us see a case right in the beginning. Ozone is a group of practitioners I know, and you have the actually leisure, you have the luxury of having another anesthesiologist with you. But see, if you are alone in a case in a nursing home and a case of cleft palate, 9 months, 8 kgs, mildly hypognaathic child, mouth opening is good and you think you can intubate, not a problem. So you induce with propofol and scoline, and mask ventilation is also easy. But on direct laryngoscopy, you see epiglottis, cords are seen intermittently. So strong anterior pressure is required. Endotracheal tube number 4 is not going. So you ask for a smaller tube. Your assistant is fumbling to find the smaller tube. He can't see whether the tube is smaller or bigger. He's giving you some tube. The tube drops on the floor. The saturation also starts dropping. Then you ventilate with 100% oxygen. Then you find out the tube, the saturation is up again. But by the time you do another scopy, you realize that the child has come out of scoline now, and you are wondering whether to give a second dose of scoline, and when you are alone, single-handed. So like this, the story goes on. So are these cases, cleft lip palate cases, or pediatric case? Yes, in some way. So the chances of you need a general anesthetic with the endotracheal tube. You are sharing the airway with the surgeon. The surgeon is right there inside, associated with large number of syndromes, and the airway is difficult in many of these. And the airway, which was already difficult, now post-operatively, there's a swelling of that airway, so it can get compromised further. We are associated with Smile Train since 2008, and we have done more than 3,000 of these cleft lip palate cases. The extent of cleft surgery is on one side a minor, only a unilateral incomplete cleft, to a bilateral cleft or incomplete bilateral or complete bilateral, and a cleft palate. So a cleft palate is supposed to be a more major surgery than a cleft lip or unilateral cleft lip. Incomplete cleft lip is supposed to be minor. So there are challenges in preoperative, intraoperative, as well as postoperative periods for an anesthesiologist, which are unique to this cleft lip palate patients. And let us see what they are one by one. In a history taking, the child may have failure to thrive. Then mainly this is because of nutritional problems. So if the child gives, there is history of failure to thrive, the child is not putting on weight, and history of cyanotic spells, then you must suspect that the child may have a congenital heart disease. If the child is sleeping in prone position and snoring, then the child may have difficult airway. Child may have URTI. So history is very important, history taking. And many of these patients, the parents are not well versed, they are not educated, they are from poor social background, so they are unable to give you any history. So we have to be very careful actually in history taking. In examination, you will see all this, the nutrition, presence of URTI, whether any syndromes are there, and how is the airway. So coming to nutrition, the anemia is because of they can't feed properly, or it may be physiologic anemia. But the anemia can be rapidly corrected by oral iron supplements. So at our hospital, we accept the lower limit of hemoglobin as for cleft lip 8 grams and for palate as 10 grams. Because at our hospital, we see that very less bleeding, we are very careful and cautious surgeons. So we even accept the 8 grams of hemoglobin for a cleft lip. But of course, it depends on individual hospitals, what should be their lower limit of hemoglobin. Now, if the child has the upper respiratory infections, which are very common in these patients because there is a mixing of food and air in their pharynx because of the cleft. So what is the problem if they have upper respiratory infection is they have a hyperreactive airways, and even if there is a history of URTI, they can lead to a postoperative laryngospasm or bronchospasm, which are common in this age group patients. So if the patient has a running nose, if the patient has a upper respiratory infection, what would you do? A conservative approach would be to postpone the surgery for 4 weeks or 8 weeks. But it is very difficult in this patient when you postpone, and when you call the child again, the child will come with another fresh episode of URTI. So there is a dilemma. I mean, what to do if the patient has a respiratory infection, whether to give the case or not, because it is definitely predisposing to a postoperative or intraoperative bronchospasm and laryngospasm. So it is very clear, with guidelines are clear when to postpone this child. So any child, we know that we would postpone if any child is having a florid upper respiratory infection, the child is looking lethargic, dull, child has fever, if any of this, if it is present, has a purulent nasal discharge, if there is a productive cough, if there are rhonchi, then obviously you would postpone. So if there is upper respiratory infection like this, you would postpone for 2 to 4 weeks. And if there is a pneumonia, then you would postpone for 4 to 6 weeks. So this is clear when will you postpone. But the dilemma is when whether to postpone a child with just mild running nose. Because they will tell you, so till yesterday he was fine. Now today morning, because we came on a two-wheeler, the child is having running nose. Or the child is already having taking treatment for upper respiratory infection. So can you give such a case? That is a dilemma. And here we can consider all these points that if this child, whether this child is looking active now or the child is dull, the child is looking active, playful, a child is smiling, then you can give this case. If the cleft is less severe, that if it is only an incomplete lip, then you can give. If the age of the child, the more the age, the safety increases, lesser the age, the problems will increase. And the most important is the comfort and experience of anesthesiologist. If the anesthesiologist is used to, if it's a pediatric anesthesiologist and the setup is comfortable for the anesthesiologist, then he can give such a case. And every case should be individualized. Like, if it's a patient and your experience setup is also good, but you feel that there is a difficult airway. So if it is a patient with periorbital sequence, obviously you will not want any URTI in this patient. So you will want absolutely dry and absolutely healthy child if the child is already having some other problem. So it has to be individualized. Now, these children are having many congenital anomalies and a large number of syndromes are associated with cleft patients. So the common syndromes are associated with limbs and cardiovascular systems and vertebral column. But we are mainly concerned with the cardiovascular anomalies. So the left to right shunts like VSD, ASD, PDA are there, and very rarely a right to left shunt also is maybe present with the child. So cyanotic heart disease may be there. And you have to be careful if it is a cyanotic heart disease. So you need to diagnose it beforehand. You must suspect a congenital heart disease if the child has history of failure to thrive or cyanotic spells, a low birth weight, and a murmur. But it is better said than done because a murmur is very difficult to be heard in a child who is crying, the child who is tachycardiac. It is difficult to hear a murmur. Some of these right to left shunts on when the child is resting, there is no murmur. So if you suspect that the child might have a cardiac problem, then you should go for a preoperative echo. And it is needless to say that any child who is diagnosed congenital heart disease must receive a prophylactic subacute bacterial endocarditis prophylaxis. So these are some other syndromes which are associated with cleft. Like commonly a Pierre-Robin sequence is there. So it's not a syndrome. Pierre-Robin is a sequence, and that means it's a combination of these symptoms: micrognathia, that means a short mandible; glossoptosis, that means a big tongue; and respiratory obstruction. So if these three are there, then it's the Pierre-Robin sequence. So usually a Pierre-Robin sequence patient becomes easier to intubate with age. So you can wait for the surgery and let the child grow up a bit. Unlike these other syndromes like Treacher-Collins, the intubation may become more difficult with age. And all these other syndromes are associated, though rare, associated with the cleft lip and palate patients. And all these, some of these children are having labeled as Pierre-Robin sequence and some of them are not. So I want to highlight that even if they are not called a Pierre-Robin, they can be very hypognathic and all these isolated cleft palates. That means where the lip deformity is not there and only the palate deformity is there. So these isolated cleft palate patients can be very difficult to intubate and they are hypognathic and they may not be labeled as a Pierre-Robin sequence, but they are equally difficult intubations. So you must be careful while taking on such patients. So coming to airway assessment, our traditional assessment like Malampatti is of no use because the child will not open his mouth and will not cooperate. So you need history, if there's a history of snoring or sleeping in prone, then, but if there's a history of tongue-lip adhesion in the neonatal period, some of these Pierre-Robin children, they cannot breathe when they immediately after birth because of the large tongue. So the tongue is stitched to the lower lip And if the surgery is done like this, then it predicts extreme difficulty in intubation. But the good news is majority of these non-syndromic clefts, like the clefts which don't have any syndromes, they are easy to intubate. And most of those who are difficult to intubate are easy to ventilate. So you can come out of the situation. But you need a very good assistance for all these, and your assistant needs to be used to for all this. Like in this photo, we can see that the assistant has held the head with his one hand. With the other hand, the assistant is giving anterior laryngeal pressure. So you need very good assistance for doing all these cases. This is a Copu scale which you can determine how difficult the airway can be, and it will take into consideration points like whether the chin is normal or hypognathic, how is the mouth opening, are there any previous intubations and history of difficult intubations, whether the uvula is seen or not, what is the range of neck movements. So depending on, they give the points to all this and decide whether the intubation is going to be difficult or not. So Copu scale is a more objective scale to label whether the patient will have difficult intubation or not. Coming to investigations, we do normal investigation like CBC and the triple H. The PTINR is done only in cleft palate patients. Blood grouping is done. At our center, we don't cross match for every palate patient. X-ray chest is done only to rule out LRTI and not done routinely. And 2D echo only if you suspect any cardiac anomalies. Now coming to the nil-by mouth guidelines, like commonly we follow the formula feeds and any cow's milk 6 hours and 4 hours for breastfeeding and 2 hours for clear liquids. Now again, I want to tell you that all these are the parents are not educated, so they don't understand the meaning of this. And you must, before taking up the patient, again, you must confirm that the child is nil by mouth and confirm from the mother, tell her that if the child is not nil by mouth, the child can have problems. And because many of them, when the child starts crying, they give milk. So you have to be very careful in this NBM guidelines. Coming to anesthesia management, at our center, we give a pre-medication of oral midazolam. Our usual preparation midazolam, what we use, that is given orally 0.5 milligrams per kilogram, or even pedicloryl we can give. Then intravenous pre-medication, I give fentanyl and glycopyrrolate and a lot of intravenous drugs. So actually it's a polypharmacy, but they are important. So dexamethasone is given, tranexamic acid is given to all palate patients. Ondansetron and Dexa is given to all the patients of cleft lip and palate to reduce the postoperative nausea, vomiting, and Dexona is very useful as a analgesic also. So coming to the induction of anesthesia, you can go for inhalational or intravenous induction. There are advantages of both. The inhalational induction can be smooth if you give a good pre-medication. And the intravenous induction, I generally prefer intravenous induction if the child has any other problems, like child has a cardiac problem or a child has a difficult airway, then I prefer intravenous induction. You must have an intravenous line before embarking on anything. So the problem here is you need a venous access before induction, and these patients can have really very difficult venous access. If you pre-medicate orally, it helps. The local ointment like Prilox, it will help. A distraction of the child, like nowadays with the mobile phones, you can distract the child. And needless to say that you need expert assistance. If you want to take a peripheral line, a patient who is moving, the vein finder or rarely USG guidance also will be required, because some of these patients who keep coming repeatedly for surgeries, they have very bad venous access. All their veins are fired beforehand. Now coming to intubation, they have difficulty in intubating a non-syndromic cleft, and it is mainly because of hypognathia. So here we can use a video laryngoscope. You can see in the video. When you are using video laryngoscope, you might require anterior pressure as is given here, and you need a stellated endotracheal tube. If the patient has hypognathia, it is better that you use a stellate. And when you use a video laryngoscope, this is a Macintosh based video laryngoscope. You can see the cords, but the tube doesn't reach there. So this problem you can tackle with the help of a stellate. Another problem can be if there is a left-sided alveolar cleft. What happens is the laryngoscope blade slides into the cleft. So the solution to this is you take a roll of gauze and put it into that cleft, and then the flange of your laryngoscope, you rest on that gauze piece roll. so that the depth, the height of that your view is not compromised. So this role you can shift into the cleft like this, like you can see in the video. If there is a bilateral cleft and a prominent premaxilla, then that premaxilla comes in your vision, and again the intubation might be difficult because it is right in front of your eyes. When you see the cords, the premaxilla is standing there. This is a difficult airway cart. Should contain all size endotracheal tubes, steelets, oral nasal airways. A video laryngoscope two are there, which are available in pediatric sizes. The Medicam, which is the Macintosh type video laryngoscope, and the air track, which is a channel video laryngoscope. So they are fairly reasonable in their price. So we can have them easily, and all different size eye gels, LMS, cricothyrotomy kit, all this should be there in your difficult airway cart. Then there is a predicted difficult airway. You must, of course, keep the difficult airway cart ready. It should be ready for use just besides you on your right hand side. It should be ready, laid down. And a second anesthesiologist is very preferable. You can, at Ozone Group, you can very easily have this. And inhalational induction is preferred. Spontaneous respiration is preferred. You must always confirm if ventilation is possible before giving the relaxant. Apneic oxygenation you can give by simply putting the nasal oxygen cannula from beforehand, and that will give you some more extra time. Now, it is important in these to only do a maximum 2 or 3 attempts at intubation. Remember, don't remain fixated on intubating, and actually the airway, which is an anatomically difficult airway because of hypognathia, can fast become a physiologically difficult airway, and there can be a severe laryngospasm if you continue to intubate. So you must limit your attempts at intubation, and the next attempts should be done only by a senior anesthesiologist. So you can ventilate and come out and postpone the case if the particular case is taking more than 3 attempts. It is very, very important to follow this principle. The intubation ring Ardere Elvin, the RA tubes, which are South Pole tubes, are preferred. And we generally use micro cuff tubes. If you don't have micro cuff, you can go for plain tubes, but don't use the Portex cuff tubes because they have a very big long cuff, and the proximal part of the cuff can really come in between the cords. So it is important to use either the micro cuff or then use the plain tube simply. Now, for this surgery, they need a very extended neck position. So, and in this extended neck, you cannot intubate. So, you have to intubate first and then give this position. So, it's quite a jugglery, and you need again trained assistants to give this position after the anesthesia. We maintain generally with O2 or air, O2 plus mixture of air and nitrous and sevoflurane or isoflurane. I generally use cisatracurium. The IV fluids, usually I use ringer lactate. And a burette set is very important because see this patient, suppose the patient is as 5 kgs and you accidentally give 100 ml or 200 ml bolus to this patient. It becomes too much of a hypervolemia for this child. So if you are using a burette set and only a 50 ml solution is taken in this, then even if accidentally it is all the 50 is given, not much of a problem has still occurred. And will you add glucose or not? So I previously never used to add glucose. We used to give just plain ringer lactate. But since we are giving the maxillary blocks, I have noticed that sometimes very alarmingly low sugars are there, and sometimes sugars are as low as 50 or 40. So we are monitoring intraoperative sugars, and whenever we are giving these blocks, maxillary blocks, I will add glucose to the ringer lactate solution. So either a 2% or a 4% DRL we use. The throat pack is always done by a surgeon. And monitoring, we monitor pulse, blood pressure, saturation in adult CO2. Temperature is very important to monitor because we have small children, and the blood loss is important to monitor. It is difficult to say exactly how much blood is lost, and for very small children, an important method is you can weigh the swabs and weigh the swabs beforehand and then afterwards and see the difference, and that is the blood loss. You need to monitor certain events which are like putting the Dingman's mouth gag. Dingman's mouth gag is put in the patient's mouth so that the surgical exposure is done, and a lot of head movements occur when the surgeon is putting this gag. So the tube can literally go in, become endobronchial, or it can come out also. So the tube can come out in your hand So you need to be very vigilant when the surgeon is putting Ringman's gag. The tube can get kinked. All sorts of things have happened in my OT. When the surgeon is giving, another is local infiltration. It can go intravascular. And the blood loss also you need to monitor. Hypothermia you must prevent, and most important is to control the ambient temperature, and you can use forced air warmer or the heating mattresses. The temperature probe has to be there on the patient. Now, at the end of surgery, you need to do a careful throat suction, and for that, the patient needs to be deep. When we switch off the volatile agents, we give one dose of propofol, 1 milligram per kilogram, and even Xylocard, the intravenous lignocaine, 1 to 1.5 milligrams per kg, and taking the patient deep under propofol, and you will do direct laryngoscopy to see whether the throat pack is removed, whether there is adequate hemostasis, and then it is followed by a reversal. So the question of whether awake or deep extubation is again controversial, but at my place, I do a deep extubation, then I give the lateral position, I oxygenate the patient nicely, and I wait till the patient comes out. Because if you try to awake extubate, there is too much of coughing and a lot of problems post extubation, spasms happen. So it is better to extubate them deep as far as our setup is concerned. Now, coming to analgesia, we give them a multimodal analgesia, and which starts from intraoperative period. We give opioids, fentanyl, and the blocks. So either the surgeon gives local infiltration blocks, or we give the intraorbital or the maxillary blocks. Those we'll see in details. All patients are given dexamethasone, which is excellent anti-inflammatory, and dexmedetomidine is also given. So nowadays we are giving it in the block solution. So I don't give it IV. If it is not given in the block, then you can give it intravenous also. It's an excellent drug. And the analgesia is continued in the postoperative period with the paracetamol suppository and ibuprofen oral syrups. So this is a part of multimodal analgesia regimen that we follow. The surgeon gives either the local infiltration, so he will block the greater, lesser, and nasopalatine nerves. So if we are giving blocks, you need to watch the total dose of lignocaine and bupivacaine. The total dose of drugs need to be watched. So this is a video for infraorbital block. This is the gingival approach. See how there is a difficulty in putting, when the syringe you are passing from one side, the tube is coming in the way, so you need to adjust there. Basically, you want to direct your needle towards that side pupil, and you also want to palpate on the face of the child where the needle tip is, so that there is no accidental puncture of orbit or something. Then aspirate, always aspirate before injecting, and we use bupivacaine 0.25%, 1 to 1.5 cc solution for this, and the bilateral block is given. So infraorbital bilateral block is given for a cleft lip patient, and a bilateral maxillary block is given for a cleft palate patient. So this is a ultrasound guided block. You can see that the probe is kept. So the solution you can see in the pterygopalatine fossa. This is the USG guided block, where you keep the probe below the zygoma, and you are looking at the pterygopalatine fossa from below, and you are injecting from above. So suprazygomatic approach you are taking. The needle is going from suprazygomatic area. And so needle shaft you can see. You don't see needle tip here. You can see the needle shaft, and you can see that the fluid is getting into the pterygopalatine fossa, and the fossa is getting filled from below. So this is a recently described block, and I'm giving since 2 years. And I'm adding dexmedetomidine in this bupivacaine 0.25% solution. So after we are giving this block, we have noted that there is absolute reduction in the emergence delirium, and even the sugars drop too. That means it is giving a very good analgesia. Now coming to the other problems because of airway sharing, the endotracheal tube can get kinked or can get obstructed. The mouth gag can press the endotracheal tube. The saturation, how will you know the saturation will stop, drop, and the EtCO2 will rise? The endobronchial intubation can be there. There's a lot of movement of head in this because the surgeon is all the time adjusting the tube, the Dingman gag is adjusting. So the movement is almost Throughout the surgery, there is a movement of the head is occurring. This is a very dreaded complication, accidental extubation, and believe me, it has happened with me. So most feared complication, but you have to keep calm. Remember, you have intubated once, so you can intubate again. So most important is not to remain fixated on intubation, and most important is first you should, when the Dingman gag is already there, you stop nitrous oxide and do oral suction and remove the throat pack, and then only remove the gag, because when the gag is there, it is right in front of you, the wide area is there, so you can really remove the packs and do suction very nicely when the gag is there, though the saturation is dropping now. So you remove everything from the mouth and then only remove the gag, and then hold a 100% oxygen mask. You can ventilate even if there is a small bleeding in the mouth, no problem, because the oxygenation is most important. And then you can intubate. You need to adjust the head position because this is the extended head. It is difficult to intubate in this, so assistant needs to hold the head in the neutral position. And you can actually sensitize the surgeon that this accidental extubation can occur. So you need to keep on telling the surgeon that, okay, when you are doing intraoral movements, see how it happens. Because of some instrument, the tube gets hooked into the instrument and the tube comes out. So if your surgeon is senior and you have discussed all this with the surgeon, then he will take the adequate care and you can prevent this from happening. Excessive bleeding can occur. So all these measures you can take: the local infiltration with adrenaline. Every patient you must give the tranexamic acid. Maintain adequate depth of anesthesia. See to it that your end tidal CO2 is adequately low. And the pulse rate should be controlled. All these measures, if you take, the bleeding will be less. And important is avoiding hypervolemia. So in a 5 kg child, if you give him 100-200 fluid fast, then that becomes almost 10-20% of his blood volume. And this hypervolemia itself will lead to increase in bleeding. So all these measures you can take to reduce the bleeding. Airway obstruction, post-extubation, most important reason is a retained throat pack, and it has happened. Though we employ checklists, there are WHO checklists to see that whether the pack is removed or not, still it keeps happening. And so you must always confirm from the surgeon that whether the pack is removed or not. Ask the surgeon, ask the assistant, and the dictum we follow is the one who puts it will remove it. So surgeon has put it, the surgeon will remove. Sometimes they put two packs and pack is really out of your vision. So when you do chexoscopy, you can't see the pack. So when surgeon knows that he has put two packs, so he has to remove two packs. The check laryngoscopy to suck out clots and ensure hemostasis. And also you must confirm removal of pack. Another thing is airway obstruction. So the airway which is already compromised because of hypognathia, and the child is used to breathing from that big gap in the palate, and now there is reduced space because of closure of the palate. And the palate, when it is closed, there is edema of the tissues also. So all the time, all the more the airway is reduced. The tongue is swollen because of mouth gag. There is a venous engorgement of the tongue, so there is swelling of tongue. The soft tissue in the pharynx also are swollen. So all this lead to a swelling of airway and a compromised airway in the postoperative period. So if the child is hypognathic, you can use nasal or oral airways. So airways has to be well lubricated, and it can be put before extubation also, so that you can see the tip of the nasal airway and you can confirm that it is not too much inside the throat. The tip of the airway has to be just below the uvula. And for that, you need to keep out the nasal airway. Quite a bit of it has to come out because they are hypognathic children, and that airway space is literally very less. So almost a 2, 3, 4 centimeter of the nasal airway is jutting out when the other tip of the airway is in the pharynx. The nasal airway in case of pharyngeal flap has to be very carefully put only by the surgeon because it can result in torrential bleeding. Nowadays, I prefer even the oral airways, and very good silicone rubber material is there, clear silicone material, and soft oral airways are available. So well lubricated soft airways if there. Even the oral airway is very good for these hypognathic patients. A laryngospasm, if it is partial, then you will hear a stridor, and if there is only a movement of the chest and complete silence, like no sound, it can be very dangerous, or because it can be a complete laryngospasm. So how will you treat? With the CPAP, a continuous positive airway pressure with 100% oxygen. And injection Xylocard is very helpful to reduce the airway reactivity. So how will you prevent laryngospasm from occurring? You can extubate in deeper planes, extubate during inspiration carefully, and pre-medication with dexamethasone. In treating laryngospasm, adrenaline nebulization is also very helpful. And what you can do is put one ampule adrenaline in 5 cc's of normal saline and give that nebulized. After extubation, you can give that. If there is a bronchospasm and the child is still intubated, you can give a nebulized levosalbutamol via T connection. So inline nebulization you can do if there is a bronchospasm. The emergence delirium is a very irritating problem, and for the caregivers as well as the parents become very anxious because the child continues to cry, continues to howl, and all the predisposing factors for emergence delirium are present in a cleft child, that is age less than 5 years, sevoflurane anesthesia, head neck surgeries, and anxious child and parents. So how you can prevent the emergence by giving very good pre-medication. Using propofol will also reduce the emergence, and intraoperative dexmedetomidine or even a propofol at the end of surgery can prevent your emergence delirium, and a very good post-operative analgesia you need. So all this will prevent emergence delirium. Now, after we are giving the blocks with maxillary blocks with the sonography, we have seen that absolutely there is immediate post-operative emergence delirium is almost zero incidence. So to conclude, anesthetizing small children for cleft lip and palate can be challenging for the non-experienced anesthesiologist. So you must, in the pre-anesthesia checkup, you must look for any syndromes, any cardiac anomalies, whether the child has difficult airway or whether the child has history of ERTI. And there are unique problems in these, like airway sharing with the surgeon. But with the surgeon, you also share an important goal, and that is the safety of the child. So if you have effective communication between the surgeon and anesthesiologist and you work as a team, you can solve all these problems. Intubation as well as extubation in this patient is very critical, and monitoring throughout the recovery for airway obstruction has to be done, especially for patients who have a difficult airway. A multimodal analgesia is essential for an optimal recovery. And these are some of us, our happy patients. Thank you.